All right, so when we mobilise the fibular head, often the fibular head translates posteriorly. So using the metacarpal joint of my hand, I'm going to get bone-on-bone contact on the fibular head, and then just using leverage, I can flex the knee, and because of the resistance of my metacarpal joint, what's happening here is fibular head is mobilising anteriorly. So this is the mobilising at a speed and force that the patient could overcome. We can just take that to the paraphysiological limits and then apply a rapid manipulative force, and that has that manipulative effect on that joint. Fibular head, metacarpal joint, those two coming together. Just need to adjust the flesh so it's as bone on bone as you can get, and then distal hand using a leverage force. Grab hold at the distal part of the tibia, not on the foot because then we get ankle and plantar flexion. Grab hold of the tibia, take up the tension, premature cavitation there. It happens because Ben's just a young man. All right, and that's the pulsing action like so. And then I can do the manipulative force when we cut on the other point. Excellent. Right. Talus, typical translation pattern is coming anterior or anteromedially. So what we're going to do is contact the medial aspect of the talar head with my metacarpal joint, and then going to use my distal hand to drive the talus posteriorly. And again, take up the tissue tension, and then we can just pulse using upper body weight as a mobilisation effect. To get a manipulative force into the joint, I'm going to use the drop piece here, which will help us generate a momentum to create a manipulative force. Again, take up the tension, and then good. Beautiful. Give me 5.